Today, we dive into the cutting edge of medical breakthroughs, a revolutionary approach on rotator cuff repair, and a pioneering diagnostic solution for melanoma. I'm Olga Villaverde. Access Health starts right now. Each year, over 500,000 Americans undergo rotator cuff surgery in search of relief. However, with high post-operative failure rates impacting 1 in 5 patients due to issues like poor healing, extended recovery periods, or re-tearing, the need for improved outcomes is more urgent than ever. So today, we're looking at bioinductive implants, an exciting innovation in rotator cuff repair. But first, let's meet Denise.
I have been flying for 37 years. We are required to push and pull carts that can weigh about 300 pounds. The job that I do, closing overhead bins, carrying heavy metal trays, over all the years, it just was wear and tear. I couldn't lift my arm over my shoulder. It was just sharp pains. It really affected me because I like being busy. I have a big family. I have a great group of friends that we all like to get together. We rollerblade, we do planks, we do all kinds of athletic things, and it takes a toll on your body when you can't do certain things, especially with having grandchildren and wanting to pick them up and roll around and enjoy life. Just pick up and go. You realize, ouch, I can't do certain things. In 2020, I decided to take 8 months off to see if I could rest it, hoping ice and more exercise would assist the healing process, but nothing would happen. So I decided to speak to Dr. Simovic. So we had an interview. The shoulder had some calcification and a partial tear, and he recommended that we'll do a little bit of therapy, but it got to a point that I just couldn't use my arm. I couldn't raise my arm. It was just too painful. So Dr. Simovic said it would be best if we move forward. So we moved forward with the decision to have surgery.
Joining me now is Dr. Ryan Simovic, a board-certified orthopedic surgeon and sports medicine expert. He also specializes in complex shoulder conditions. Welcome, doctor.
Thank you.
So let's start, doctor, with just what are the most common causes of rotator cuff conditions?
So the most common cause of rotator cuff tends to be degenerative changes in the rotator cuff. It's one of these things that's age-related changes of the tendon. The tendon gets weaker as time goes on, but there's also traumatic tears of the rotator cuff. For example, from a fall or from skiing, things like that nature. There are 4 rotator cuff tendons in the shoulder. Each one of them has a different function. Some are to elevate the arm, others are to rotate the arm and give strength, but they provide a stability to the shoulder so that the arm has meaningful motion. And when things go wrong with the rotator cuff, generally it results in pain, limited range of motion, diminished function. A lot of patients will be affected in terms of how they play sports. Some will have difficulty at work. Others just have a difficulty with what we call activities of daily living, or ADLs. And so the common pathway is pain. And a lot of these patients will have a fair bit of pain during the day, but especially at night. And so when the rotator cuff tears happen, patients tend to have a lot of debilitation.
Can it heal on its own?
So that's the problem with rotator cuff tears. They just don't heal on their own. So I always like to tell patients partial thickness tears, which would be tears that are through part of the tendon but not fully through the tendon, will tend to eventually turn into higher grade partial tears, and partial tears eventually progress to full thickness tears, and full thickness tears then get bigger as time goes on. Unfortunately, the body is not able to heal it on its own. Some patients can improve without surgery, but the tendon actually never heals by itself.
What do people normally do when they get one? Like they'll put a heating pad, they'll put ice, ibuprofen, right?
Yeah, so I think generally that's the case, which is a lot of patients initially will think that some rest will help, void motion will help, they'll do ice, they'll do Advil. I think those things can be helpful sometimes at getting rid of some of the symptoms, but unfortunately it's one of those things that the tendon does not heal. So those things are not going to fix the problem.
So what are some types of rotator cuff repairs?
So the typical treatment for rotator cuff tears is usually repairing the tendon, and the way we historically do that is through use of what we call suture anchors and sutures, where we go in arthroscopically and we put these anchors that look like drywall screws into the bone that have sutures like thread that comes out, and as we tie the thread, it ties the tendon back down to the bone, and that's usually how we treat most rotator cuff tears. Some tears respond to conservative treatment, which you kind of alluded to, which would be anti-inflammatories and therapy, but from a structural standpoint, fixing them usually means suture and suture anchors.
And is that why post-operative failure rates are so high?
That's part of it, because the biology of tendon repair is just so poor. The common theme with them is that it's a very avascular area. There's not a lot of blood flow to that area. There's very few places in the body where there's such little blood flow, but the fact that there's so little blood flow there makes it that even if you were to reattach the tendon, there's a chance that it's not going to heal.
So there's more to be done. There's something else that we can look forward to?
Well, there is. I think that's the most exciting part, is that a lot of our techniques have changed over time. The way we repair tendons, the way we treat partial thickness tears, that's changed. And our implants are better than ever. We're able to more securely fix a tendon, but the rates of failure are still pretty high. And so the fortunate thing is there's been a lot of advances now in the biology of tendon healing, and particularly utilizing bioinductive implants. And so there's one bioinductive implant called REGENETEN, which I've used now for over a decade. And that's really been a significant change beyond anything else in trying to improve the biologic healing of these rotator cuff tears.
And we're going to talk about that. I'm going to take a quick break, but I want to hear about that. So when we come back, more on this. We'll be right back. Welcome back, everyone. We are here with Dr. Simovic, who is talking about an enhanced healing solution for after rotator cuff surgery. All right, doctor, so we talked briefly before the break about an innovation. Tell me more.
So the REGENETEN bioinductive implant, it's type 1 collagen, which is what tendons are made out of, and it's a size of a postage stamp. And during this procedure, we lay it over the top of the tendon, and then we use a secure fixation device that's able to fix it to the tendon and the bone without having to use sutures. Once it's fixed over the tendon, that's essentially the procedure. And this implant is then going to resorb after 6 months, and in the process of resorbing, it's going to increase the thickness of the tendon. So I definitely use it for all types of rotator cuff tears. We can use it for partial thickness tears, we can use it for full thickness rotator cuff tears, and partial thickness rotator cuff tears. The nice thing is we don't have to use suture anchors and sutures to repair the rotator cuff. We simply place this bioinductive implant over the top, and once the REGENETEN's over that, it exerts its biologic effect. Again, over 6 months, it's increasing the tendon thickness. When we do it for full thickness rotator cuff tears, we then fix rotator cuff tears with suture anchors and sutures, but in order to aid the biologic healing, we then put the REGENETEN bioinductive implant over the top of the rotator cuff once fixed.
It sounds like this could be truly an effective solution for so many.
It is. It's very applicable to most rotator cuff tears and really can help patients tremendously.
Did you recommend this for Denise?
I did.
How did she do?
She did great. So she had a partial thickness rotator cuff tear, had some calcification, or what we call calcific tendonitis. Normally, that's a relatively difficult recovery, especially if you put suture anchors and sutures in. For her, we didn't have to. We simply removed the calcific deposit. We cleaned up the rotator cuff tendon. We put the bioinductive implant over the top, and she did great.
Let's see how she's doing. Let's check in with her.
Sounds good.
Let's do it.
When it came time for surgery, Dr. Simovic really took the time to explain what he was going to do. He was going to go in and apply the collagen implant to speed up the recovery. And after 3 weeks, I believe I was out of my sling and able to use my body, and it gave me the ability to really do everything that I love, especially be with my family and the kids and just love on them and be able to pick them up and swim with them and get back to work. And I'm so fortunate and so grateful that I am able to have mobility that I want without pain. I would highly encourage anyone that is in such pain with their shoulder to go with the collagen implant. It has really helped me. I really enjoyed being back, fully recovered and ready to move forward.
Wow, Denise is doing really good. Any final thoughts, doctor?
She really is. You know, so for 2 decades, I've been a shoulder surgeon. For the last decade, I've been using the REGENETEN bioinductive implant. Just like Denise, it's helped a lot of patients. Whereas we've been flirting with really high failure rates over the course of the last 2 decades, we're now starting to see this transcended. We're starting to see patients succeed where they weren't before. And it's really been an exciting technology advance.
Love it. Thank you so much for the information.
Thank you.
Thank you, doctor. And if you want more information on this subject that we discussed today, visit regeneten.com. You can always check out our website, accesshealth.tv.
Melanoma is an invasive form of cancer that begins in the melanocytes, the cells that color the skin. It is often referred to as the most serious skin cancer because it can spread to other parts of the body. Although the least common type of skin cancer, it can also be the most dangerous. How do you know if you have it? If diagnosed, what happens next? For Morgan, her routine dermatologist visits and visual inspections of a changing mole did not seem thorough enough.
I didn't know much about melanoma until it was almost too late. When I'm at the barn, I'm not thinking about work. I'm not thinking about the cancer diagnosis. I'm only thinking about spending time with my horse and us getting better as a team. We compete in shows all over the Southeast. It's something I've been doing since I was 12 years old. I think we have a really special bond. On some of my darkest days, he certainly made them much brighter. He was a constant in my life when everything was just in disarray. So a few years ago, I went to see my dermatologist for just a routine skin check. There was a freckle on my forearm that I'd always had, but had gotten slightly raised, so that concerned me a little bit. She didn't seem too alarmed by it, so I just brushed it off. It's nothing, but as the months and weeks went on, I noticed that it started to get bigger and bigger. So I went to another dermatologist for a second opinion. He also looked at the mole and said that it didn't look anything out of the ordinary to him. So I left that appointment thinking, okay, I guess I'm just crazy. A couple more weeks went by. One day I noticed that it was bleeding, and I knew that was a sign that it could be something more. And so that's when I went back to my dermatologist and demanded that it be removed and biopsied. So after the biopsy, was obviously very anxious waiting those results, and I was just getting ready for work one morning and saw that it was my dermatologist's office calling me, and it was like 7 a.m. And my doctor told me that the biopsy had come back as stage 2 melanoma.
Dr. Erin Farberg is a board-certified dermatologist specializing in advanced surgical care for patients with skin cancer.
Melanoma is a very serious cancer, and if it's not caught soon enough, it can be deadly. The diagnostic process in identifying a melanoma begins with really identifying a suspicious lesion. There's a lot of different technologies out there, but the gold standard is to do a skin biopsy, where we actually remove that portion of the skin and then evaluate it under a microscope.
I learned that melanoma is one of the most metastatic cancers, that it was also very rare in someone my age. I knew that the spot had been there for several months and that the margins on my biopsy were not clear. So there was definitely still cancer left in my forearm. And my thought process is, there's still cancer in there. It spreads really quickly. I need to get it removed as quickly as possible.
After you have that diagnosis, you move on to staging. Staging systems are very important, such as the AJCC or NCCN. What they do is they bin patients with similar characteristics so that we can also understand what their prognosis is. Essentially, what is their chance of cancer coming back or metastasizing? However, there's inherent limitations to binning and staging patients. Unfortunately, more than 60% of the melanoma deaths actually occur in patients that were originally diagnosed as stage 1 or stage 2. The primary treatment for melanoma is surgery. We're able to excise the melanoma out, and for most patients, that's all we need to do. However, there's always some small percentage that have a recurrence or a metastasis. And our goal is to either prevent or avoid that, or if it's going to happen, we want to be able to catch it as early as possible.
The doctor recommended a sentinel lymph node biopsy. And I was, really confused. Why would they need to take lymph nodes for skin cancer? I thought you're supposed to cut it out. So why would they need to do something so invasive?
A sentinel node is answering the question of, has this disease already metastasized? The sentinel lymph node biopsy procedure does not come without risk. Now, we do have various guidelines that help provide guardrails as to who's appropriate for this procedure, but guidelines like the NCCN also state that you should individualize your treatment management for every patient. There are emerging technologies to help us identify a patient's risk, and one of those is gene expression profiling, or GEP. The advantages of gene expression profiling is that it evaluates a tumor, in this case, a melanoma's RNA. RNA is actually the instruction book, and so we can really identify and understand each tumor's individualized risk. We're actually identifying genes within these tumors to better understand what their behavior will be. It allows us to make more collaborative and informed decisions.
I was doing a lot of research because I myself work in cancer diagnostics. I know how important personalized medicine is for patients. I came across the Decision DX-Melanoma test that would give me a better picture of my melanoma specific to me. So I reached out to my dermatologist and requested that they run that test on my biopsy sample.
Decision DX-Melanoma is a validated 31 gene expression profile GEP test that was developed to identify the risk of recurrence or metastasis, including the likelihood of sentinel lymph node positivity for patients with stage 1, 2, or 3 melanoma, and inform patient management decisions.
The Decision DX-Melanoma test report provides a significant amount of actionable information. Now I know what my patient's actual specific risk is of having a positive sentinel lymph node. This really helps us identify who is most appropriate for this procedure. We can have a better understanding of who really should undergo a sentinel lymph node biopsy surgery, or identify patients that can forego the procedure entirely. I'm able to understand what is their risk of metastasis, what is their risk of recurrence, and then from there we can customize, we can personalize what our management is going to be together.
When I got my results back from the Decision DX-Melanoma test, I saw that my sentinel node positivity score was 20%, which is actually really high. And seeing that number made me really upset to know that my biopsy would likely be positive. But it also gave me time to think and prepare. And I did have a positive sentinel node, which made me stage 3B melanoma.
Decision DX-Melanoma has been shown to be associated with improved patient survival and has been studied in more than 10,000 patient samples.
There's exciting new data out from the National Cancer Institute utilizing the SEER database. And the data evaluated the validity of the Decision DX-Melanoma test. What they found was that the Decision DX-Melanoma test was associated with improved survival. Now, of course, the test isn't making the patients live longer. It's understanding each patient's individualized risk and then making management changes that are aligned with those patients' risk. It's those management changes that have led to improved overall survival for our patients diagnosed with invasive melanoma.
So I've been off my treatment for about 8-9 months now, and I'm doing really well. I get imaging done every 3 months. And before my imaging tests, I get really anxious that I'm going to have more cancer in a lymph node, or that I may have cancer in another site. I pull out that Decision DX-Melanoma test that tells me that likelihood of distant metastasis is actually relatively low, and that helps calm me down. My advice to anyone would be, if you see a spot on your skin that's new, if you see a spot that's changing, go get it checked out.
For more information on Decision DX-Melanoma, visit mymelanoma.com, and as always, you can go to our website, accesshealth.tv.
Thanks so much for joining us. Remember to head to our website, accesshealth.tv, for more information. Until next time, you take care.